Right, hello. I'm Claire Fuller, I'm a GP from Surrey and I lead the Surrey Heartlands Health and Care Partnership. So, conversation I've just been having is nobody seems to know where Surrey is, which is completely fair enough. And I realise as I put this map up that it's meaningless, isn't it? So just to put it into context, that's London, that's the sea, that's Kent and Dover and France, and that's Cornwall. So that's Surrey. So I come from Surrey Heartlands and I will be the only person you ever hear say that. So Surrey Heartlands is not a real place. We are most of Surrey, but we are not all of Surrey. We're a pragmatic collection of 3 places that came together to work to improve the health outcomes of a population. There are 3 things different about Surrey Heartlands. So as you know, there are 44 STPs at the moment across the country. Every STP is looking to do integration, is looking to improve access to general practice, and looking to improve access to mental health. We are doing all those things. If you look at all the plans, they're all very similar. There are 3 things that we are doing that are slightly different, which I'm going to spend a little bit of time talking about. So we've signed a devolution deal. So there's Manchester and Surrey, obvious. Who knew? Then we have Surrey Heartlands Academy, which is our approach to clinical leadership and very much our home for where we are handling for our approach to population health management. And then our approach to citizen engagement. And I have to say that's been, I'll talk about that in a minute, but it's been one of the things that's changed the way I have done work. Because of our devolution deal, we work really closely with our local authority. And local authority do citizen engagement much better than we do in the NHS. They actually do it properly. And from having learned how, they have researchers that actually do this, and having seen how we should be doing citizen engagement has transformed how I think we should be doing clinical engagement. So, this is my favourite slide at the moment. This is what devolution is all about. So again, like population health management, you'll hear lots of people talking about devolution and what does the word mean? For us, what devolution means is about joining and uniting the public sector spend across the whole range to make sure that we can influence our population's health outcomes in the best possible way. So, if we work as the NHS in isolation, we will only ever improve our population's health outcomes by 20%. So it doesn't really matter how good your diabetes pathway is, how good your cataract pathway is. It's obvious, really. If you are homeless, if you're an alcoholic, if you're out of work, your health will always be worse. So unless we combine and start dealing with the prevention issues and with the much broader, the social, the wider determinants, we will never actually bring about true population health improvement. This is our jigsaw slide, which talks about how we do citizen engagement. So Surrey is full of retired head teachers, retired civil servants, retired captains of industry, who in their retirement often acquire 1 or 2 long-term conditions about which they become very knowledgeable, very vocal, and very capable of disrailing an agenda. So what we have done is, because of course those points of views are very relevant, so we have our stakeholder group with lots of very articulate shouting going on. But to counteract that, having worked with the Surrey County Council, we have created what we call a citizen panel. So Rich Stockley, who's led this work, used to work at Ipsos Mori. And what we've actually done is gone around knocking on doors and recruiting demographically representatives from each one of our postcodes to make sure we have a true representative of what people think. So the only exceptions to that, we've over-recruited carers and we've over-recruited people with disabilities to make sure that their voice is statistically significant within the mix. Currently got 1,300 on the panel, and that will go up to 3,000 by the autumn. And we use that panel, we send every 6 weeks, there's a rolling programme of questions that go to them. They've currently had things about mental health. The one that's out at the moment is on cardiovascular. So one of our needs is to increase the prevalence of hypertension. So we have underdiagnosed hypertension, and those that we have diagnosed, we're not looking after well. So one of our population outcomes we're trying to improve is that we will have 10 fewer strokes in Surrey every month. But to do that, we need to increase hypertension diagnosis and also increase diagnosis of atrial fibrillation. So the things that have gone out to the panel have been things like where should you have your blood pressure measured? So it sort of starts off saying it will be by a GP and a GP consultation, and it gradually goes down to ascertain really what the level of comfort is from the population until it sort of ends up, are you happy to have your blood pressure measured in the supermarket? Are you happy to have it done at a garage? So that we can actually broaden out where we're measuring people's blood pressures and actually find people that we wouldn't otherwise reach. Part of the jigsaw as well is also our citizen ambassador model. So in conjunction with Health Watch, we've recruited citizen ambassadors to each one of our work streams who sit within the work stream as critical friends. And actually we've also got non-exec members from our organisational boards that also sit within the work stream, again giving that assurance and oversight of what we're doing. This is about the slide about our academy, which is really, if you think about it, it's an umbrella term for our clinical leadership activities. So the initial remit was to react to the GIRFT and the right care data. So it's really to remove the unwarranted variation and to standardise care, so no matter where you are, we know that your outcomes will be the same. And we've created a number of different pillars and different ways to support that overall aim. So we have a clinical leadership group that are accountable for setting the outcomes as a system and for then embedding those outcomes within their organisations. And that's easier said than it actually is done. So in terms of when you start looking at stroke, to actually go from we're going to improve stroke to being we're going to reduce the number of strokes by 10 every single month is quite hard because everybody wants to say, well, we're going to find 20 more people with blood pressure or we're going to anticoagulate people more. But that is a meaningless number to the people that live in Surrey. And because we are a Devo population, we are accountable to our population, and our senior decision-making board has elected members on it. And this, again, has been one of the interesting things, and one of the things that really changed the way I've thought about things, is starting to talk about the work we're doing in terms, and it sounds obvious, but actually talking about work in terms of impact it has to population and at place. And once you start trying to say, why am I doing this? What difference will it make to my parents live in Surrey as well. So what impact will this have on my mum or on my dad or on my children? And until you can articulate the change that you're doing in those terms, you probably shouldn't be doing it. So we have the clinical leadership group. We then have the clinical and citizen engagement bit. So the way we're doing the clinical engagement, so clinicians can be like citizens. So you will know we have a number of bow-tied medical directors that again are able to derail either an orthopaedic review or a stroke review because they want to carry on sticking stents in everybody in their local hospital. So to counteract what are really quite powerful voices, again, and this will be the job for the autumn, we're setting up an infrastructure where we can democratically recruit clinicians as a counterweight to what are really quite loud and powerful voices. And the voice, we're medically dominated, and it's really hard to stop that in terms of loud voices in rooms because the medics tend to be the ones that come. But we're actively, again, recruiting our AHPs, so the 14 types of AHPs who don't get a voice but are actually often the most creative in terms of service change, our nurses, our physician's assistants, our paramedics, our pharmacists, making sure, again, by postcode or by organisation, that they are democratically represented and can inform the outcome setting. So as a pathway, as a topic comes to the outcome setting forum, it will have been informed by a demographically representative reference group that can then feed in as a counterweight. We're combining all our knowledge management and evidence, so all the data as it comes in. We're combining our CCG resource with our local authority resource in the first instance, and we'll then go on to bring the provider resource in as well. So it's one data set, it's one version of the truth that we can all then share. Quality improvement, we've had IHI that have come in and worked with us a couple of weeks ago. And what we're looking at doing is trying to create a single methodology for us as a system. Because one of the things that happens is, we were talking about it earlier actually, about how language can get in the way. So we've got a couple of trusts that have done IHI. We've got one that's a lean trust. We've got somebody else that's just on the NHSI plus quality improvement bit. And people become very territorial about their techniques and about the language that, you'll be a black belt in whatever else, or you'll be a whatever else it might be. So we are working on a defined population using the IHI, going around taking the best from all the methodologies to create a single way of working. So our looked after children do very badly in Surrey. So our children overall do better than average, but our looked after children do much worse than looked after children around the country for various. We've had a failed Ofsted and it's a historic problem. So our health inequality for our looked after children is shocking. And so unless we can level that up and address that, when it doesn't really matter what goes on for the rest of the population, because the care of this group is getting worse. So as a quality improvement system exercise, we are looking at how we look after our looked after children, because each one of our 10 organisations will have an interaction with looked after children, and unless we can improve it collectively, we will fall down and fail our children again. So innovation research, our academy has been in partnership with the HSN, and we've had some staff seconded across, which have been really successful. And we've got a MOU signed with the HSN, with the Clinical Research Network, and we're working really closely with the university. And we ran Surrey Expo in March, which was triggered by, we sent a grassroots call out to all of our workforce saying, what could we do differently with digital? What innovations would you like to see? What could we do? We got about 60 responses, which I thought was pretty good, really. And we set up an event where we brought in industry partners to meet and work with our clinicians about what we could do differently. We've had 3 or 4 quite interesting projects that have sprung up as a result of that. So these are our priorities. It's always very reassuring hearing Amanda talk, because actually it's always very good when you come from another part of the country to understand that you're not on your own doing these things. So our priorities for this year, as yours, will be the establishment of our neighbourhoods, of our 30 to 50,000 populations for our GPs. So they're all clustered, they're all together, and how that feeds into our places, our integrated care partnerships, which we've got 3 of, and how that then feeds into our integrated care system. So we're a much smaller population than you, and I think one of our learnings over the last couple of months is there's a lot of stuff that we're going to need to do with partners, particularly some of the specialised commission, because we're too small. And actually your population is probably much more realistic in terms of the things you can do. Our major priority, though, is around the first 1,000 days on our children. So I've already talked about the looked after children. But it comes back to one of our really important principles is bringing around generational change. So apologies, it's a slightly heavy-handed analogy, but if you think about Surrey as a bathtub, and if you fill up the bathtub is the full capacity of things that we can do. You've got a tap running into it and no plug-in, so the water's running out. At the moment, we're nearly at full capacity, so the water is just at the edge, just at the top. When we hit winter, we're constantly mopping the floor because we've got more capacity than we can actually deal with. What we have to do is start to turn the tap rather than constantly mopping the floor. So apologies, it's heavy-handed, but it gets the principle across. And unless we can improve the health of our children and our next generation, we will continue tinkering and we will continue just doing more of the same, and we fundamentally need to do it differently. This is my last slide. So my 2 favourite facts are that if you enter school with a health inequality age 4, that gap will only ever get wider. And the best predictor of a health inequality age 4 is your mother's mental health age 14. So that's why we are focusing on the first 1,000 days and also investing in the mental health of our young people, because without that, the demand will only ever keep on increasing. I didn't know I'd put that one in. So that's really just saying what else we're doing. So we are evolving our assurance. We're looking to do our assurance at place as a system. Our commissioning architecture will come together with our local authority. And we're looking at how we won't do commissioning intentions this winter. We will do system aspirations. We will come up with a system plan rather than to try and get away from the old contracting planning round, which actually just reinforces old behaviours that we need to move from. So that's my email address, by Twitter bit. We have a monthly newsletter, which you're very welcome to sign up for, and that's our website. I am dashing off because I've got to get home for the football. First watching the football. But please, if you've got any questions, want to know any more, please email me or drop me a note.